Anthracycline-based chemotherapy is commonly used to treat many cancers, but unfortunately the use of anthracyclines is also associated with the development of heart dysfunction. In high-risk patients, such as older individuals or those who have traditional cardiovascular risk factors, this risk could be as high as 1 in 20. The SUCCOUR trial was designed to study strategies to prevent the development of heart dysfunction in these high-risk patients. We had two arms to the study. In the first arm, patients were followed by a standard of care approach of measuring left ventricular ejection fraction with echocardiography. In the second arm, patients were followed with the addition of global longitudinal strain, which is a more sensitive marker of heart dysfunction. Regardless of the arm, if there was a change in heart function, patients were initiated on cardioprotective therapy. When we followed these patients for the outcome, the first thing we saw that patients were followed using the GLS-based approach were identified with heart dysfunction earlier and twice as more commonly as the standard of care approach. Then when we looked at the outcome at 1 year, which is a change in heart function between the two arms, there was no difference. This considered all patients regardless of whether they received cardioprotective therapy or not. However, when we looked at the more clinically important outcome of development of cardiotoxicity, patients in the GLS-guided arm were at a significantly lower risk than the standard of care arm. So essentially what our study showed is that if you follow patients who are at high risk with a more sensitive method to identify heart dysfunction and initiate cardioprotective therapy, we can prevent the development of cardiotoxicity. So patients with cancer who are already living with one life-threatening problem, this surveillance approach can reduce the risk of developing yet another life-threatening problem, which is heart dysfunction and eventual heart failure.